I am Dr. Adeel Tahir, and I'm working as a senior technical advisor with Mercy Corps Pakistan. Uh, so I'll first talk briefly about Mercy Corps and its work in Pakistan. Mercy Corps is basically an international NGO and is working in Pakistan since 1986. And Mercy Corps is present in almost 40 countries of the world. In Pakistan, Mercy Corps is working in different sectors, but our most important work is in health sector, and in health, we are mostly focusing on tuberculosis control. For tuberculosis control, we have been the principal recipient for Global Fund since 2007. And now, currently, we are working in 91 districts of the country, which means almost 2/3 of the country, through our 6 sub-recipients that are our implementing partners. And we have our office locations in three main provinces of the country. If I talk about our current grant, we are using this CAD for TB in active case finding through our mobile vans. These mobile vans are equipped with digital X-ray machines, and they are using the software of CAD for TB. We have almost 7 vans at the moment, and 2 vans are in the process of refurbishment. From July 2021, we will have a significant expansion in our work, and we're going to continue with about 39 vans. So 30 vans will be added in our fleet, and then we will be performing chest X-rays or chest camps in 90 districts of the country. If I talk about our overview of our CAD for TB utilization and our experience with CAD for TB, so we have purchased CAD for TB boxes in December 2017, and these were installed in March 2018 in 7 of our mobile vans through Interactive Health Solutions, which is a local representative of Delft Imaging. We have ordered 2 more boxes, and these will be shortly added in our fleet. So far, we have purchased 1.1 million licenses for CAD for TB since 2018. And as I mentioned, that we are going to expand significantly from July onwards. So we have bought additional 0.8 million licenses in June 2021. So far, we have performed 104,675 X-rays from August 18 to December 2020. And in current grant, scope of ACF, as I mentioned, will be significantly increasing, and this will increase our utilization of licenses. Through our experience with CAD for TB and the scoring of the chest X-rays, we have identified certain advantages which I like to share with you. Number 1 is this CAD for TB usage provides immediate results even in outreach with no internet connectivity. As you know, Pakistan is a larger country, and we are working in almost 2/3 of the country. So there are many areas where there is an issue of internet connectivity. In those settings, these CAD for TB boxes are really helping us. It helps chest cam physicians to diagnose even when the radiologists are not present. And as you know, it saves HR, and it's also reduces the cost of X-ray film printing, because when we get the scores, only then we order for printing of the X-ray films. The persons with lesser scores, we just don't print the X-ray film from them, and it saves a lot of cost. And it's also rationalized the use of expert testing, because the CAD for TB, through this software, when we do the X-rays, we identify certain presumptives, and based on those presumptives, we go for the expert testing. This is a brief screenshot of what we are doing during our chest X-rays, keeping in mind the COVID protocols. As you can see that I try to show you an arrangement of the usual chest camp where we use the CAD for TB software. Here, this is the entrance. The patient, they usually enter from this side, and then they are seated, keeping in mind the COVID SOPs. From them, the patient moved to the desk number 1, which is the registration desk. Here, the officer sitting there, it gets the detail of the patient, their demographic details, age, sex, and any presumptive symptoms. Then the patient moved to the desk number 2, which is basically the mobile vans, which with digital X-ray mobile machine and CAD for TB software. The patient undergo chest X-ray, and his or her score is then identified or written down on the sheet. Those patients whose score is more than 70, we have decided to have a cutoff point of 70 or above. So anyone with the cutoff score of 70 or above, his or her X-ray is printed, and then the patient moves toward the desk number 3, which is the doctor's desk. So we take a doctor which is trained on national guidelines on tuberculosis with us during every chest camp. The doctor sees the chest X-rays, identify the scores, asks the patient about brief history, and then advises whether the patient needs sputum sample collection for expert testing or not. If the doctor advises sputum sample collection, the patient moves to desk number 4. Here it is the staff present is our lab technician who hand over the sputum cups to the patient and tell them how they can collect their sputum samples. Then the patient moves to some open area for sputum collection. In this way, the sputum is collected, and then the sputum collected sputum is handed over to lab technician, who then do the expert testing. Some of our mobile vans, they have expert testing built in them, and some of the mobile vans, we just some of the chest cam, we just collect the sputum samples and then we take with us and do the expert testing in the stationary sites. So in this way, this is the arrangement where we use the CAD for TB software and do the organize the chest cams. If I talk about our experience and the analysis of the data since 2018, we have done a lot of, as I mentioned, about 100,000 X-rays, and out of these, the patients with the score more than 70 are about 8,000, and out of those, 6,484 underwent expert testing. So the presumptive positivity on presumptive percentage on tested on expert is about 81%. Out of those 81% who tested on expert, we identified 1,128 MTB, and 43 of them are also are detected. So in total, we identified 1,171 patients, which means that presumptive positivity rate is about 18%, which is quite good, keeping our experience for this expert testing. If I talk about the patient who scored less than 70, we did X-rays of those patients, and out of those who scored less than 70, we found that 58,679 have scored less than 70. Of those who were tested on expert on the advice of the doctor, 5,247 were tested on expert. So the percentage of presumptive tested on expert is about 9%. We detected 375 Mycobacterium tuberculosis patient, and out of those, 9 were also detected for RR, which is multi-drug resistant tuberculosis. So in total, we have identified 384 patients out of those who have scored less than 70. If we calculate the presumptive positivity rate, it's about 7.3%. So if I analyze it with our sputum microscopy results and the data, our presumptive positivity rate is about 7% in that. So even with the score of less than 70, the presumptive positivity rate is better as compared to sputum microscopy if we don't screen the patient through X-rays. So in this way, this CAD for TB software is really helping us, and it's giving us true presumptives. Okay, when we use this CAD for TB software, we have identified certain challenges and issues, and that we timely communicated with CAD for TB representative, the Delft Imaging representative there, and I'm very thankful to them. They are very kind and helpful to us, and they are available whenever we need them. But still, there are certain limitations, and before today's meeting, we have a meeting with Delft representative, and most of the issues that I mentioned, I'll describe here. they assured that these will be resolved when we move to a higher version. Currently, we are using version 5 of CAD for TB, and they are saying that if we use version 6 or 7, most of these issues will be resolved. But for the sake of presentation, I'll share these the issues here. The current version that we are using as a limitation to process the images of the children less than 14 years of age. And I hope that with the better upgraded version, this issue will be resolved, and we will be using this X-ray scanning in children of less than 14 years of age. CAD for TB does not provide any differential diagnosis as some of other similar software do. And in the first presentation, it was described that Delft is thinking on those lines. However, currently they are more focusing on tuberculosis, but as per our discussions, hopefully in future, they'll upgrade their software in such a way that it will also diagnose certain other conditions related to lungs. It does not provide centralized information on number of licenses used. As I mentioned that we are purchasing the licenses, but we were not able to know how many licenses we have used. So it was a bit problem in planning and ordering for new purchases. But now with the new version, hopefully this issue will be resolved as well. Total time consumed in uploading and storing of images is about 2 to 3 minutes, and it becomes quite much in a busy chest cam where we almost approximately screen 100 patients in a day. So if you multiply 100 into 2 to 3 minutes, and it will take a lot of time. But again, as I mentioned, that with our talk with Delft Imaging representative, hopefully this issue will be resolved, and the processing time will be reduced to less than 1 minute. CAD for TB, the current version that we are using, it runs only on Windows 7, and it sometimes crashes. And then we need to restart it through our IT expert, and is involved, and it becomes somewhat cumbersome during because the chest cams are organized in a remote settings, and our IT expert is present centrally. So excuse me. So this becomes difficult. But now with the upgraded version, it can operate in different operating systems, and then it will also solve this issue as well. So this is a brief presentation from my side about our experience of using CAD for TB, and I must say that it's really helpful, and with better and upgraded versions, again, it will really help us even when we are foreseeing that our work will be enhanced significantly from July onwards. Thank you very much.